Therapeutic drug monitoring. Therapeutic drug monitoring is the analysis, assessment, and evaluation of circulating concentrations of drugs that we may take in the serum, plasma, or whole blood. In some cases, we need to monitor the amount of drugs in a patient's system. The purpose of this might be to ensure that the drug dosage has maximum therapeutic benefit, so it's effective, and for example, if it's an antibiotic, it'll fight off the infection, or that it's not so low that it doesn't work, okay? So you don't want to be so high that it's toxic or too low that it doesn't work. So you want to stay within that therapeutic range. It is used when safe dosage regimens have not been established and a trial and error approach is not appropriate. So it can become very toxic if too high or not strong enough if too low. So that there's not all drugs are monitored in the laboratory, but only some are. And we'll talk about which ones those are. We find the standard dosage from observations in healthy populations of people. And there's different evaluations for the circulating drug concentration. We look at many of the different factors in the ways that drugs make it into somebody's body. For example, how did they take that drug? Was it a pill? Was it intravenous through an IV or intramuscular through a shot? How about the rate of absorption? Do they have any stomach or GI issues? Okay, somebody with Crohn's disease isn't going to have real good absorption through those intestines. Distribution of the drug throughout the body. Somebody who is obese is going to have a different distribution than somebody who is very tiny. The rate of elimination is important as well. Think about your liver. Your liver processes these drugs. Your kidneys excrete these drugs. So if you have liver or kidney problems, that could create an issue as well. So there's 5 different pharmacological parameters that can determine the drug concentration within the body. I refer to this as LADME. If you can remember LADME, you're doing very well. These are liberation, absorption, distribution, metabolism, and excretion. So this is pretty much what I just talked about in the last slide. Liberation is how well that drug, or how that drug is taken. Absorption is how it's absorbed into the body, distributed throughout the body, metabolized through the liver, and excreted through the kidneys. A couple terms that you're going to need to be familiar with therapeutic drug monitoring are mechanism of action and bioavailability. The mechanism of action of a drug is the biochemical or physical process occurring at the site of action to produce the pharmacological effect. Down in the bottom left-hand side of your screen, I have an axon and a neuron. When you take an analgesic or some type of a pain relieving medication, it knows where to go to act, and that is the mechanism of action. The drug action is mediated through some type of a receptor, and cellular enzymes and structural or transport proteins are important examples of a drug. The bioavailability is a fraction of the drug absorbed into the systemic circulation. So just because you take 200 milligrams of a drug doesn't mean all of it is going to be absorbed into the systemic circulation to be used as the mechanism of action. Let's look at the different ways that you can get drugs into your body. First one, intravenous, is an IV, which is injected directly into the circulation. Then we have intramuscular, which is injected into the muscle, kind of like your tetanus shot or your flu shot. Subcutaneous is just under the skin, as you can see the picture to the right there. An example of that could be a TB skin test. Transcutaneous is inhaled or absorbed through the skin. You can see that person with a patch on their stomach there. Suppository is a rectal delivery, which is why I am not a nurse. I prefer not to give people suppositories. And oral administration by your mouth, taking an Advil or something like that. So looking at the absorption, there's a lot of things that can affect the absorption of drugs into somebody's body. For orally administered drugs, the efficiency of absorption from the GI tract depends on many different factors. For example, was it a tablet? Is it a capsule? Did you drink a liquid? As you can imagine, a liquid solution would probably be absorbed much quicker than a tablet would. It also depends on the uptake by transport mechanisms intended for dietary constituents versus passive diffusion. So how is this being transported across your intestines? What about changes in intestinal motility, the pH of the body, inflammation that may be present? What type of food did you eat? or other drugs that may be taken at the same time. We could have variations among the population. Do blacks or Asians or etc. absorb at different rates? There can be different types of genetic differences there. Age, whether you're pregnant or if you have any other pathological conditions, such as, I always bring up Crohn's disease for some reason, that's the first one that comes to my head, you're not going to be absorbing drugs the same way as a healthy person would. So once these drugs are in your circulation and processed by the liver, we need to eventually eliminate the drug. The rate of change of drug concentration over time varies continuously in relation to the concentration of the drug, so we have to take into account the metabolic clearance and the renal clearance. The metabolic clearance goes through the hepatic mixed function oxidase system. The liver is the main organ responsible for that drug metabolism. It converts hydrophobic substances into water-soluble ones so they can travel through the body more readily, and it transports them into bile or into circulation, they can then be eliminated by renal filtration. So again, the last area that would see those drugs would be the clearance through the kidneys. And the drug clearance is directly proportional to that creatinine clearance rate that we learned about. So if you have a kidney issue, you're going to have a clearance issue of these drugs. Here's a pictorial of what first order drug elimination looks like. So you take the medication instantly or right away. It's going to have a very high dose, and over time it's going to come down and decrease, as you can see here. So with this, we have to look at half-life and steady state. The half-life of a given medication is how long it takes the body to get rid of half of the dose. So the definition sounds just like the term. So here we go. When the patient is taking a medication on a regular basis, there's an ongoing process of drug absorption in the form of each dose of the drug, and concurrently an ongoing process of drug removal with the drug's metabolism and clearance. Okay? And remember, everybody's a little bit different depending on your liver and kidney function and your ability to absorb drug through your GI. So eventually there comes a point when the amount of drug going in is the same as the amount of drug taken out. When that happens, we call that steady state. It usually takes between 5 and 6 half-lives for medication to reach steady state. Therefore, medications with short half-lives reach steady state relatively quickly, while those with long half-lives take a long time to reach steady state. So by the end of the 6th or 7th dose, the amount of a drug administered in a single dose is equal to the amount being eliminated during the dosage period. All right, let's do this. All right, here's an example. You are asked, I'm going to move this up a little bit. You're asked to figure out the half-life of a drug this week. The half-life of a drug is the amount of time that it takes to reduce the amount of drug by half. It can be easy to overthink it, but it's very simple. First, we're going to figure out how many times you have to cut the amount in half. So here's the type of question you're going to be asked in your written assignment this week. Let's look at a drug level that started off at 16 milligrams per deciliter, but ended at 2 milligrams per deciliter. The first thing you have to do is see how many times you can cut that number in half to get to your ending number. 16 divided by 2 was 8. 8 divided by 2 was 4. 4 divided by 2, we get to our 2 milligrams per deciliter. It took 3 times, okay? 3 times to cut that in half, okay? So here's 1, here's 2, and here's 3, okay? Now look at the elapsed time. Divide the elapsed time by the number of times that the amount was cut in half. So let's say that it took 6 hours to get from 16 milligrams per deciliter to 2 milligrams per deciliter. You would take your 6 hours, divide it by 3, and you would have a half-life of 2 hours. That would be your half-life. Okay, a few more definitions here. Pharmacokinetics, know the definition of that being a mathematic modeling of drug concentration and circulation. This is what we use to determine those half-lives and how things work. It assists in establishing or modifying a dosage regimen. Takes into account all the factors that we just talked about: absorption, distribution, elimination, and the therapeutic response. So it's just the overall study of how all of this therapeutic drug monitoring works. So when it comes to the laboratory, sample collection becomes very important. Timing is critical. We usually draw two types of specimens, okay? A trough and a peak. A trough is where it's really low, and that's drawn just before your next dose. So you come in, you draw the patient's blood, and that would be your trough level. The nurse might give an IV medication right after you get there. And then we would draw the peak concentration 1 to 2 hours after the oral dose. It might vary for an IV or an IM type of dose. Usually we use serum or plasma. Again, the timing is very critical. Okay, if you show up at the wrong time, it's not going to be accurate. The goal of this is to make sure that it doesn't get too high that it's toxic or too low that it's not therapeutic. The picture I have in the bottom here, I'll move this down a little bit, is showing how we get to steady state. Remember about a slide or two ago, we talked about how many doses it takes to get into steady state? Here's an example of somebody taking a pill. So at 0 hours, they take a drug. It goes up, and then after about an hour, it starts to drop. So at that point, we give them another pill. Then it goes up, and it starts to drop. Okay, so we keep giving them more and more doses until they end up in that steady state. So what about the definition of minimum effective concentration and minimum toxic concentration? Therapy is achieved when the desired effect is attained because the required concentration has been reached. That concentration would set the lower limit of utility of the drug, called minimum effective concentration. Some drugs exhibit side effects at higher concentrations, which can be toxic. At some concentrations, these toxic effects become very dangerous. That concentration is called maximum therapeutic concentration or minimum toxic concentration. Patient studies have generated upper MTCs and lower MEC concentration ranges that are deemed safe and effective. We call that the therapeutic range. When you are between MEC and MTC, you are at steady state, essentially your happy place. So how do we do therapeutic drug testing in the laboratory? This testing is more expensive than your typical spectrophotometer type testing that we do in our labs or on a general chemistry analyzer. These typically use immunoassay analysis. I always call this the drop in a swimming pool test. We have to use immune components to try and pick up these things we're testing for, such as these drugs, to make them visible. To also confirm these, we might use high pressure liquid chromatography and gas chromatography. They're more sensitive, but they're expensive, time consuming, and require more expertise. Let's look at some of the therapeutic drugs. I have a reference for this in the last slide of your PowerPoints for this week, and this is from Valerie Polanski. She makes these really wonderful review cards that you can have for your boards, and I really recommend that you purchase one of her products sometime before you take your boards. Here's an example of what one of her cards looks like. She has them divided up, the different therapeutic drugs, by what they do, and this is what I really want you to know. I'm going to give you a lot of information on each of these drugs, but what's the most important thing is to know what category they fall into. For example, know that analgesics, which are pain relievers, would be salicylates and acetaminophen. Antiepileptics, which are for seizures, if you see one of these names, know it's a seizure medication. Phenobarbital, phenytoin, primidone, valproic acid, carbamazepine, ethosuximide. Okay? The antineoplastics are for chemo, methotrexate. The antibiotics I call the SINs, except for chloramphenicol. We've got the amikacin, gentamicin, neomycin, netamilcin, kanamycin, streptomycin, tobramycin, vancomycin, and then chloramphenicol. Bronchodilators, theophylline, take that for asthma. Your different cardioactives, these are antiarrhythmic types of medications, many of them. Digoxin, digitoxin, lidocaine, disopyramide, procainamide, propranolol, quinidine. So if you see one of those names, know it's a cardioactive. The psychoactives, tricyclic antidepressants, and lithium. And then, of course, the immunosuppressants, which we give patients who have just received an organ transplant to make sure that they don't reject that organ. Okay, so this is a nice little slide that gives you just a quick overview of the therapeutic drugs when you're reviewing for your boards. Let's look at the cardioactive drugs requiring therapeutic drug monitoring first. I like to talk about digoxin first and foremost because he's the one you're going to see the most often. His purpose is to treat congestive heart failure and heart arrhythmias. Okay, he inhibits sodium-potassium ATPase and helps with the antiarrhythmic type of issues. My son had a heart defect when he was born that caused his heart rate to get too high. They gave him digoxin. It worked very well to keep him from going into that high heart rate. With this one, it's a very slow process and has a very, very long half-life. All right, so some of the antiarrhythmics, once again, that you need to be familiar with. If you see one of these, say that's a cardioactive drug. Amiodarone, digoxin, digitoxin, disopyramide, lidocaine, procainamide, propranolol, and quinidine. The next group are the antibiotics. Aminoglycosides, they're sometimes called. It's a group of chemically related antibiotics used for the treatment of infections with gram-negative bacteria. And they're usually resistant to less-toxic antibiotics, so these guys can become pretty toxic. Vancomycin, gentamicin, tobramycin, amikacin, kanamycin, streptomycin, neomycin, netamycin, all of the SINs. But, of course, chloramphenicol, he's thrown in there, and I know it's not a SIN. Sorry. But those are your antibiotics. Now we have our anti-epileptic drugs. I have a little more information on some of these. You don't need to know a lot of the details, but it's kind of interesting to know that different drugs are used for different types of seizures. Phenobarbital, this one is a slow-acting one that helps control many different types of seizures. Primidone is metabolized to phenobarbital, so once you take that, it'll become phenobarbital in your body. I think that one's a little more powerful. Phenytoin, also known as Dilantin, okay? That is something that you have to be very familiar with. And I remember getting my first job in a lab, and I knew it as phenytoin, but then the reagent pack on the immunoassay analyzer said Dilantin on it. So you have to know that those two are interchangeable. It's commonly used in the treatment for seizures as well. Valproic acid, here's another one, guys, also called Depakote. Again, the analyzer, I knew it as valproic acid. The analyzer had Depakote on the reagent pack, so you're going to have to know those interchangeably. Those are for petit mal and absence types of seizures. I'm not really familiar what an absence seizure is, but it must be a type. I'm sure some of you guys out there might know. Carbamazepine is another type of seizure drug. Ethosuximide is for petit mal seizures. Levetiracetam is another seizure drug. Topiramate and felbamate. Felbamate, also called felbutol, is for severe epilepsy as well. I'm sorry, my slide kind of got cut off up here. There we go. Now you can see the little guy up there dancing. Okay, psychoactive drugs. These are important. Lithium is one that we draw for very commonly in the laboratory, and this one you need to be really careful. You cannot use a green top lithium heparin tube for this or it will contaminate it. It's usually an orally administered drug used to treat manic depression. Okay, I think they have some other things for manic depression nowadays, but this is like the old gold standard type of manic depression drug. Tricyclic antidepressants are used to treat depression, insomnia, extreme apathy, and loss of libido. Then we have the two penes, clozapine and olanzapine. These are both used to treat schizophrenia, and I always think of the penes as schizophrenia is a real peen in the butt. If you've ever known anybody, I've got a few family members who have been diagnosed with schizophrenia. It's a very challenging thing for the patient and the family to work with. So those are the two penes, clozapine and olanzapine. Next, we have our immunosuppressive drugs. Cyclosporin. This one's used to prevent host versus graft rejection. We're going to talk about this in the immunology class next quarter. But when you have transplanted organs in your body, you don't want to reject those. So these types of drugs will slow down the immune system's attack on those organs. Another one is tacrolimus, also known as FK506. This is another one where you do have to know the both names. It's 100 times more potent than cyclosporin. So if cyclosporin's not working, starting to get a little bit of rejection going on, they may bump you up to some tacrolimus. Then we have sirolimus, which is an antifungal agent that goes with those immunosuppressive type things. A lot of kidney transplant patients receive that one. And mycophenolic acid is a lymphocyte proliferation inhibitor. We don't want those T-lymphs coming in and wreaking havoc on those transplant patients either. Next one, Antineoplastics. The big one, there's more than one, methotrexate. These kill rapidly dividing cells. Cancer cells, tumor cells, divide more rapidly than normal cells, okay? So if we can kill off just the rapidly dividing cells, we can try and destroy those tumors. Now, notice the lady up in the top right-hand corner there doesn't have any hair. One of the unfortunate side effects is because it's killing rapidly dividing cells, such as cancer cells, it is also killing things like hair follicles, which are rapidly dividing as well. Another thing that I have seen this used for in the hospital are some women that had tubal pregnancies going on. A fetus is a rapidly dividing cell. And if you have that implant in a tube it could become a health or risk to the mother and could potentially kill her. So rather than destroying that tube, they give methotrexate to try and shrink that batch of cells so it doesn't burst. All right, our last one is a bronchodilator. Theophylline is quite popular, and this is a bronchodilator for asthma patients. I've also seen it given to neonates in the NICU. It relaxes the smooth muscles of the bronchial passages so that they can breathe a little bit better. And that concludes the lecture on therapeutic drug monitoring.